Hi, my name is Spencer Stott here with Maryville University. I will be performing an EENT, that is eyes, ears, nose, and throat, focused assessment with my patient. First, I start by proper hand hygiene, then I'll apply gloves, introduce myself. Hi, my name is Spencer. It's nice to meet you.
Hello.
I will be assessing you today. The first test of visual acuity is the Snellen test. Supposed to have them stand 20 feet back from the chart. Our chart is much smaller. It says 6 feet back, but it works the same. So, Ms. Marshall, if you could please stand 20 feet back from the chart and read the lowest line that you can before the letters become too obscured for you to be able to read. But first, cover your left eye.
L-T-F-P-H.
Great, that was perfect. Okay, now please do that with the right eye. Cover the right and read from left to right.
L-T-F-P-H.
Okay. All right, now read the lowest line that you can before it becomes too obscured to read, and don't cover either eye.
L-T-F-P-H.
Perfect. These numbers on the right here indicate her visual acuity. 20/20, for example, she was able to read, meaning at 20 feet, my patient was able to read what a person with normal vision can read at 20 feet. Next is the visual fields test called the confrontation test. Ms. Marshall, I'm going to have you close your right eye, and I'm going to close my left eye, and so the eye on this side is the same eye open as it is on this side. We're going to divide our vision now into quadrants. For Ms. Marshall, we have the supranasal, infranasal, supratemporal, infratemporal. And that's going to be the same thing for me. At that halfway point, I'm going to hold up at the infratemporal location, right at the edge of my visual field, a number of fingers, and she's supposed to be able to tell me what she sees. I, of course, have to be able to see it too. This is right at the edge of my vision. How many fingers do you see?
2.
We do the same for the infratemporal.
1.
Again, we want to go about halfway between us.
3.
Okay, now we're going to go to the supranasal. That was infranasal, now supranasal.
2.
Perfect. Now we're going to do the other eye. Close that other eye for us. Good. Going to go the supratemporal,
2.
infratemporal,
1.
infratemporal,
1.
supratemporal.
2.
Very good. Next, we're assessing the eyebrows. We're looking at the shape, the coarseness, and the outer extension to temporal canthus. Ms. Marshall, if you want to grab a seat. Good. Eyebrows aren't too thin, not too coarse. These things might indicate, for example, hormonal abnormality, like hypothyroidism, for example. If we have the outer brow here extending somewhere before the edge of the temporal canthus, then that could be an indicator of hypothyroidism, for example. All right, Ms. Marshall, we're going to check the orbital area now for periorbital edema, excessive redundant tissues, lesions. If you have yellow lesions, it could be a sign of lipid deposits, showing that you have issues with lipid metabolism. And so first do a visual check. If it requires, you can palpate and you can look. Edema could be a sign of some kind of an allergy or sensitivity or perhaps congestive heart failure. I'm now going to observe your eyelids. Close your eyes for me nice and soft. Okay, observing for fasciculations or tremors. Good, open your eyes as wide as you can. Close your eyes now tight, observing your ability to do so. Now looking around the margin, we've got no flakiness, no redness or swelling. That's good. Eyelashes are on both eyelids and are curving outward away from the globe. I'm going to palpate now for nodules. Okay, now observing for ptosis. If your upper lid is obscuring your pupil or obscuring more of the iris than in one eye than the other, then we could have ptosis. I'm not noting that. Okay, good eyes. Okay, I'm now going to assess your conjunctiva and sclera. Okay, first I can palpate for lacrimal gland punctuation. Good, now I'm going to hold the brow here and bring that lower lid down and have you look up that way. With my pen light I can illuminate, look for any trauma like subconjunctival hemorrhage, anything like discharge or foreign bodies. I'm not noting any of that. I'm going to do that on this side as well. Have you turn toward me. Up and to the right. Good, nothing like that. Also looking for pterygium, and that is extension of the conjunctiva past the corneal rim, and I'm not noting any of that. And we're good. Okay, now I want to assess the clarity of the cornea, looking for no innervation of blood vessels, and that's good. I also want to see the sensitivity of the cornea as well. That should elicit a blink, showing the trigeminal nerve is innervated. Now I want to see of any arcus, and that's a cloudy deposition of lipids around the rim of the cornea, sometimes around the entire rim there. None of that. Good. Now I want to look at the irides. The color should be the same on both sides. Now the pupillary characteristics, we've got size, centeredness, that all looks good. Also want to look at direct and consensual response to light. And so we do that by shining light in the same eye and observing that pupil and its direct response. Then giving that eye a break and then shining that light in that same eye, only changing my observance to the other pupil and looking for a consensual response, which should be acting in the same manner as that first pupil. Okay, so this whole time I'm looking, this whole time I'm shining here, and I'll be looking at alternate areas. So here we have direct, pupils have constricted, give it a rest. Now I'm looking for consensual on the other side. Consensual, pupillary constriction. Now I'm going to do the same with this eye, observing first, direct, constriction, very good, give it a break. And now observing for consensual. Good, pupillary constriction. And that is it. I will now assess your extraocular muscles, starting with your corneal light reflex. About 10 centimeters away, I will shine a light in the center and observe the relative location of that reflected light in each eye. And they should be in the same locations, and they are. Next, I'm doing the cover-uncover test, where I'll have you look at an object 10 feet away, maintain that focus on that object, whatever I do here in the foreground. I'm going to cover one eye, and I'm going to observe potential movement in the uncovered eye, and that can indicate strabismus if there is movement. So maintain that focus. Observing that uncovered eye, we have no movement. Now I'm going to cover the other eye, that eye again, and I'm going to observe, maintain that focus. I'm going to observe that eye once newly uncovered, and again there is no movement. So we've got no strabismus. Get that focus again at that object 10 feet away. I'm going to do the same with the other eye, covering this, observing the other for movement. No movement. Going to cover that again, and I'm going to observe the newly uncovered eye, and no movement. No strabismus. Now we observe for the 6 cardinal fields of gaze. We're going to have your patient hold their head completely still and follow an object of focus only with their eyes. So now we start with their upper left, lateral left, lower left. And while doing so, you can ask them to check to see if they're seeing anything in double. Upper right, lateral right, lower right. Also, you want to observe their eye movement. If you have any sudden jets of the eye going one direction and then having it slowly move back into place, then they might have what's called nystagmus. Now I'm using the ophthalmoscope, and because everyone's eyes are different, you have to kind of discover your own refractory power. At anterior portions of the eye, while I'm assessing, I'll be at an 8, and when I'm looking at posterior portions, I'll be looking at about a 6 power. Okay. So first I want to look for, flip that light on, and tell your patient, if you become uncomfortable at any point, you can stop this exam, you can take a break, because this can be very uncomfortable with the light shining directly into your eye. So at that higher diopter, I'm looking at the anterior portions first, and I'm going to cover the right side of her brow with my left hand, and I'm going to observe with my right eye. First, anterior portions, looking for lens clarity. Good. I'm seeing red reflex already, but you can stand about arm's length away and find the appropriate diopter, and once you do, you'll see kind of a red-shaped, pupil-shaped coloration of red appearing in both of the eyes. Okay? Going back to the appropriate diopter, I'm going to 6 now. Again, with the opposite hand and with the right eye here, I'm looking into the eye, looking at posterior portions. You want to get nice and close. Now I'm observing for the optic disc, which is yellow in color, yellow to pinkish, and is clear on the margins. And then you're going to want to follow up all of the blood vessels. Blood vessels, you're looking for pulsation. If you see anything like herniation, that's obviously a problem. Okay, you're going to want to follow a supranasal, infranasal, supratemporal, infratemporal, and into the lateral sides as well. And then you do the same on the other eye. 6. Aneurysms, I meant, not herniations. Perfect. Thank you. Now I'm going to assess the macula, lastly, which would be a discolored region, avascular, hanging out by the optic disc, about the optic disc's width, away from the optic disc. Now I'm looking for depth of the anterior chamber. I'm going to hold the light tangentially, that's temporally, to the side of the observed eye. And then I'm going to observe the nasal portion of the limbus for shadow or lack thereof. If I see the light is not illuminating the nasal portion, then the anterior chamber is shallow. If I see the light is illuminating, then the anterior chamber is normal. Good, and we're normal. Now we're going to observe the ears, starting with the auricles and the mastoid area. Okay, so first I want to look at size and shape. You can compare, looking for symmetry, any landmarks, lesions, looking at the color. Also I want to palpate in the mastoid area, hoping for no nodules, any signs of infection, any tenderness noted?
No.
Miss Marshall, I will assess now your auditory canal, pulling forward on the tragus. I can straighten that ear canal going into the auditory meatus. I'm assessing for cerumen, which is minimal. There's no impactions. There are no inflammation or redness, no sign of infection. I can see your auditory meatus. I'm sorry, I can see your tympanic membrane, which is pearly. Movement and mobility seem appropriate. The shape is appropriate. I'm not seeing any. I can actually see the ossicles behind it. No perforations.
Mm-hmm.
Let me know if there's any pain while doing this. If you do it appropriately, there should not be any pain. Okay, now we're assessing for hearing. Hearing, pretty simple. You can just assess for appropriateness of responses during your assessment. But then there's also this tuning fork here that you can do. This is called the Weber test. You activate the fork, sticking the base at the crown of the head. Do you hear it louder on either side?
No.
Is it the same on both sides?
Yes.
Good. And that's a pass on that. Now we test for bone conduction versus air conduction in the Renee test. Tell me when you stop hearing this as I hold the base of this over your mastoid process.
No.
Now tell me when you stop hearing this.
No.
Now the latter was air conduction, and we want that ratio to be about 2 to 1, meaning air conduction should be greater than bone conduction. Sometimes it'll be 3 to 1, but 2 to 1 at least indicates that hearing is appropriate. Now your patient is sitting away from you. I'm going to do the whisper test. First occlude the tragus here and rub it. Is that obscuring your hearing pretty well?
Somewhat.
Okay, so press a little bit harder. How's that?
Yeah.
Okay. About arm's length away, you whisper into that ear a set of numbers and letters. A, G, 6. Repeat that. What did you hear?
A, G, 6.
Good. Okay, then we do the other side, and we repeat that step. How is that occluded? Is that well?
Yes.
Good.
D, A, 5.
Great. Okay, and it'd probably be good to use letters and numbers that you might not mix up, like T or D, B or P, but she passed that. Now I want to take a look at your nose. Okay, so I want to look anteriorly. I also want to look, so anteriorly, laterally, and inferiorly. If you want to face me real quick. Okay, we didn't seem to have any changes in bone or cartilage, no asymmetrical on the outside. And now let's take a look at the size, the shape, the color of the nose. I'm palpating for displacement. Any pain?
No.
Good, no masses. Now the patency of nares. I want you to occlude one nostril and breathe in and out. Now occlude the other nostril. Breathe in and out. Any resistance on either side?
No.
Okay. Now I'm going to have an inferior view of the nares. Going inside. Medially I should see a septum, and laterally I'm assessing for what's called turbinates. Both are appropriate in size. Both are symmetrical. Okay. Any difficulty breathing or smelling?
No.
Okay, I don't see any perforations. And now I want to look at your sinuses. First the frontal, which is up here, and when we palpate the frontal, we go under the brow here. Any pain?
No.
Okay. This side now. Any pain?
No.
Okay, and when we percuss the frontal sinus, we go on top. Any pain?
No.
Okay. Any pain?
No.
Now for maxillary sinus, we go up and under the cheekbone and press up. Any pain?
No.
Okay. Pain?
No.
Now palpating. Pain?
No.
Pain?
No.
Good. Now I want to inspect and palpate the mouth and throat. I'm going to look at the internal and external lips. The color, everything is pink. There's no swelling, no nodules. I'm checking for edema. I want to open the mouth real quick. I'm going to look at the gingiva or the gums. No swelling, no separation. I want to see your tongue. Now looking for color, symmetry. Stick that out for me. Good. Okay, go right and left. Good. We're looking at the hypoglossal nerve here. I'm going to stick it out for me a few times. Good. Go against the pressure of my, at the inside of your cheek, stick your tongue out and go against the pressure. Put your tongue, there you go. And then we'll go this side. Good. Both are appropriate. I'm, again, looking at your tongue. I'm looking for lesions, any tenderness present, anything like that?
No.
Okay. Now looking at the tongue, I want to see for any ulcerations. We're good on that. I want to look for uvular eyes. Open up. Now say ah.
Ah.
Good, that did so. Now we're going to look, say ah again.
Ah.
I'm looking at your tonsils. There's no swelling there, no discharge, no apparent infection. The posterior wall of the pharynx, again, no swelling or discharge. Lastly, I want to assess the gag reflex. I'm going to the posterior portion of the tongue. Sometimes you'll have to hit the uvula or go even further. Good. And that is present. And that is the EENT assessment. Thank you very much.